Okay, so on this slide, we're going to go a little more in depth on that kidney function and look at disorders that occur when the kidneys are not functioning correctly. Here are your learning objectives for Chapter 48. Okay, so just a recap for our kidney function. Remember from Chapter 47, we talked about how the kidneys filter waste, help to regulate the fluid and electrolyte balance of the body, and helps maintain that acid-base balance as well through retention of fluids, sodiums, excretion of potassium, and things like that. They also help to produce erythropoietin, which helps with red blood cell production and helps produce renin. And remember, renin is used in that RAS system to help with blood pressure control. Kidneys also help with activating vitamin D and helping with bone health. And then we talked a little bit about how when kidney function declines, toxins start accumulate, and that can have systemic effects. If you don't, at this point, know the function of the kidneys, you'll need to go back and revisit that or do Chapter 47 first. Okay, so we're going to talk about one of the first disorders of our kidneys. We're going to talk about acute kidney injury, AKI. This is also called acute renal failure. So acute kidney failure or acute renal injury is a sudden decline in kidney functioning, resulting in the inability for that kidney to maintain acid-base balance, the inability to regulate the fluid and electrolyte balance, and the inability to filter waste. So what happens when our kidneys are not able to filter waste and appropriately maintain fluid and electrolyte or acid balance is that we will have an accumulation of those waste products, specifically that BUN and creatinine. So those you'll see will start to elevate. Now, AKI is a sudden decline in that kidney functioning. So what you'll have with your lab results are a severe sudden increase of the BUN and creatinine. You're also going to notice a fluid and electrolyte disturbance that you'll see on labs as well. When we look at acute kidney injury, there are three main categories or causes of this, and it's broken down into pre-renal, meaning before the blood gets to the kidneys, intrarenal or inside of the kidney itself, and post-renal, which is something that would be causing damage to the kidneys that's after the actual kidney itself. So we'll talk a little bit about these, and hopefully by the end this will make more sense to you, because this is really important information to know these three categories. So when we look at pre-renal, this is before the kidney. So this is something that might damage or cause a decrease of blood flow to the kidneys itself. So that kidney doesn't have the blood there to be able to filter and to be able to do its job. So examples of this would be something like hypovolemia or hemorrhage. If the patient is bleeding out, right, losing severe, massive amounts of blood, and they don't have that volume there to perfuse the kidneys, then that blood flow will not get to the kidneys itself. And so that causes damage to the kidneys because they're essentially like a dried sponge, right? That they're not filled with blood to be able to filter through the blood and manage that hydration status. So when we think about pre-renal, think about what's going to stop the blood flow getting to the kidneys. Now, when we look at intrarenal, that's inside of the kidneys, and this has direct kidney tissue damage. So anything that can directly cause that kidney tissue to become damaged and not be able to filter and regulate acid, base, and fluid and electrolytes. So that's going to be things like nephrotoxic drugs, so NSAIDs or aminoglycosides. Glomerulonephritis will be also part of that damage of that inside of that kidney, because remember the glomerulus is that filtration part of the kidney. So if those are damaged, then that would cause a direct damage to the tissue of the kidneys. So that would be intrarenal or inside the kidney. When we look at post-renal causes, this is anything that might stop the flow of urine or the outflow of blood from that kidney after the kidney, okay? So this is post-renal or after kidney. So things like this might be maybe a catheter blockage or retention due to BPH, kidney stones or things like that. that are after the kidney in those ureters that might block that flow of urine and cause that to backflow up into the kidneys and cause damage to those kidneys. So that's going to be post-renal. So your three main categories of AKI or acute kidney injury is pre-renal, meaning before the kidneys, intrarenal, inside of the kidneys, and post-renal, which is after the kidneys. So all of these cause low perfusion or direct injury to those kidneys, which causes an increase in BUN, an increase in creatinine, and a decrease of that GFR. So those kidneys are not able to filter. Those kidneys can start showing decreased urine output. So remember, if they have less than 30 mLs of urine every hour, you're going to want to notify the doctor. Making sure that we assess for retention of any waste and electrolytes. So we're looking at lab levels, looking for an increase in sodium or potassium. And then we're looking for signs and symptoms of that metabolic acidosis, which is caused by an increased BUN and creatinine. We're going to talk about the phases of kidneys. This is another level of understanding that you should have, the different phases of acute kidney injury and what you'll see in your patients. We're going to talk about that on the next slide. Okay, so we have our phases of acute kidney injury. This is again important to understand so that you're able to recognize cues in your patient, anticipate treatments, and evaluate if those treatments are working for this acute kidney injury. Now, initially, we have our initiation or our onset of AKI. This can occur pretty rapidly. It can occur over a couple of hours to a couple of days. And so we want to really identify the correct cause of that kidney injury with is it pre-renal, intrarenal, or post-renal causes so that we can fix the problem that's occurring that's causing this kidney injury or kidney failure to occur. The patient will enter into what's called the oliguric phase. And so what we'll see with our patient is over the first couple days to a week or so, the patient will start having a decrease of urine output. The patient will start having less than 400 mLs per day, and we'll start to see that electrolyte imbalance and those BUN and creatinine levels increasing. What we'll start to see in our patient is that they're going to start having probably some edema, some signs of fluid overload. Their kidneys are just not functioning at all. They also may have signs and symptoms of that metabolic acidosis. So lab levels are going to be elevated and changed. They're going to have hyperkalemia and hyponatremia. So we'll be watching for this. Then what they move into is that diuretic phase. So once we fix the problem, meaning we remove the kidney obstruction or we give fluids to kind of kick those kidneys back into gear, then what we'll see is an increase in our urine output. So our body says, oh, okay, now we fixed the problem. My kidneys are starting to heal, so I'm going to start working again. And we're going to have a severe increase of urine output. So about 1 to 5 liters per day is what we'll see. So that's quite a lot of urine. And so what happens when we're flushing all that urine out and we're having 1 to 5 liters per day, we actually have a decrease in that sodium level and potassium levels in the body. So we really want to pay attention to their mentation status, right? Because if we have a low sodium level, we're going to have changes in our mentation. We'll maybe have seizures, coma, death. And then if we have changes in our potassium level, meaning hypokalemia, we're going to want to pay attention to our heart rhythm and our cardiac function. During this time, our big worry is that we're going to diurese or get rid of our fluids so quickly that we're going to then move into that dehydration status. So you'll want to monitor vital signs, looking for low blood pressure, high heart rate, things that would indicate your patient is dehydrated. During this time, the kidneys are still kind of unable to concentrate that urine, but the BUN and creatinine levels will start to normalize. So you'll see that change in your lab levels as well. Then once our body begins to normalize, your lab levels will normalize, and that kidney function starts to return back to normal. This is called the recovery phase. Your GFR will start to return towards normal, and that BUN and creatinine levels that have plateaued will then start to decrease. So we'll see a more normal functioning of our patients. During that recovery phase, again, your lab levels will go back to normal, your patient's mentation will come back to normal, and their urine output will go back to that 1 to 2 liters per day. So overall, during AKI, what we want to make sure is we recognize cues of AKI. So what are we looking for? What are those causes, the 3 causes of AKI, and then those 3 phases. And in those 3 phases, what cues would we see? What treatment would we anticipate? So during the oliguric phase, when we are not making enough urine, oftentimes patients will get IV fluid hydration. So we will start to bolus the patient or give them IV fluids, normal saline, to try to kick those kidneys back into gear. We might give them sodium bicarb, which is kind of a buffering IV fluid add-in that helps to buffer the toxins in those kidneys. If we have any issues with hyperkalemia, remember we're going to treat that. So we might be giving Kxalate or insulin to help push that potassium into the cells and lower that potassium level, as well as avoiding nephrotoxins. So if it's a nephrotoxic cause due to this acute kidney injury, we'll want to decrease those medications. Remember, we talked about IV contrast could be a cause of this acute kidney injury. So we'll do a lot of fluid hydration to try to get those kidneys to kick back in and filter through that IV contrast. During this time, we want to also make sure to monitor strict INOs. So what goes in must come out. Do daily weights, monitor those vitals and heart rhythms, monitor labs. We want to make sure that we either replace those fluids, making sure that we restart those kidneys, or restrict fluids if the provider feels that they're fluid overloaded to begin with. So you might kind of have a balance that we play with those patients. Our diets, depending on what our lab shows, don't forget, if they're high in sodium, we'll give them a low sodium diet. If they're high in potassium, give them a low potassium diet. So remember things in the diet as well. They are unable to really filter out proteins, so they may do a low protein diet, especially during that oliguric phase. For your patients in AKI, if we're not able to get them restarted, get that fluid off, and get their kidneys working with any Lasix or IV fluids, then we may need to give the patient short-term dialysis. Dialysis is initiated, especially if they have persistent hyperkalemia, since that can be detrimental to the heart. If they have extreme fluid overload that's not responding to Lasix or other diuretics, and if they have severe acidosis or uremia, which is causing changes in mentation. Usually AKI is pretty good for its prognosis. It's usually reversible, especially if we catch it early. Some patients, though, may progress to what we call chronic kidney disease or CKD, which we'll talk about in a later slide. But just know that usually AKI is treatable, and we'll get them fixed up pretty quickly. Okay, so your clinical manifestations or your cues for AKI, remember, initially when they are in that oliguric phase, they're going to have either oliguria, which means less than 400, or they'll be anuric, which is less than 100. So either minimal urine output to no output whatsoever. They're going to start having fluid overload, which you'll see with edema. So you'll check for pitting edema, looking at that on the extremities. You'll listen to those lungs and listen to lung sounds. Crackles are an indication of fluid overload. And then hypertension, the blood pressure, or tachycardia with the heart rate. For your patients, they may have hyperkalemia or hyponatremia, so electrolyte imbalances. They'll have that metabolic acidosis due to a buildup of those toxins in the blood, and they may have fatigue or confusion due to that toxin buildup and changes in their sodium levels. So we really want to catch those cues and pay attention to those. Okay, so here's another visual slide of your nursing interventions specifically related to AKI. So main goals that we talked about in the previous slide was making sure that we monitor labs and intake and output. We may need to increase fluids to get the kidney started or restrict fluids if we're seeing signs of fluid overload. Make sure we get rid of the cause or restrict the cause, like nephrotoxic drugs, get rid of kidney stones, replace blood if it's a hemorrhage patient. So just kind of recognizing the cause and fixing that cause. Paying attention to diet, making sure they're on a renal diet, which is low protein, low potassium, low sodium, and then educate on reporting any changes in that urine output and those subjective and objective findings that we have with our urinary assessment. Okay, so now we're going to talk about chronic kidney disease or CKD. This is also known as chronic renal failure. So this is a progressive and irreversible loss of kidney function. So compared to AKI, where it's a short term, it can be fixed, it's rapid. This is a slower progressing, but oftentimes irreversible. So we can't fix this kidney function. Usually this lasts 3 months or longer and is diagnosed or indicated by the kidney's inability to maintain their fluid and electrolyte balance, acid-base balance, and getting rid of those wastes. Over time, this can lead to that uremia and leads to that buildup of toxic waste in the blood. So we want to really assess this and be able to treat it correctly. So oftentimes, CKD is due to the damage of those nephrons. This can lead to a decrease in the GFR, our glomerular filtration rate, and leads to an accumulation of those wastes and fluids. Now, this can lead to a systemic list of problems. So our kidneys go down, it ties to our lungs, our heart, our body. So we kind of see a whole system that starts to become dysfunctional. As those nephrons are destroyed, the remaining ones start to hypertrophy and work harder. And so over time, those compensatory mechanisms start to fail. And so we have symptoms of the buildup of uremia, and we start to see those electrolyte imbalances, and we start to see multi-organ effects that occur. So some of our common causes of CKD that we see a lot of is going to be chronic infections or medications that are nephrotoxic, patients taking those frequently, things like NSAIDs or recurrent pyelonephritis cases. We also have patients who have diabetes, and so diabetic nephropathy is really something that damages those kidneys a lot. This can be due to chronic hyperglycemia, which damages those glomeruli. Chronic hypertension is another thing that can cause vascular and glomerular sclerosis or scarring of those glomeruli. Glomerulonephritis, which we're going to talk about later in this lecture, is an inflammation of those filtering units, and that can also cause chronic kidney disease as well. Prolonged obstruction, if we don't catch BPH or we don't catch kidney stones long term, those can also cause chronic kidney disease to occur as well. So some things that we're going to talk about is going to be the stages of chronic kidney disease, what your patient's going to look like, what the treatment is going to be, and some of those lab levels and diagnostic findings that we'll come to expect with chronic kidney disease. So those levels are usually really important to understand, and how we diagnose chronic kidney disease based on some of our diagnostic findings. Okay, so we're going to look at our stages of chronic kidney disease, and this is going to be based on that GFR, so our glomerular filtration rate. Remember I said that's really important in diagnosing what stage of chronic kidney disease your patient will have. So when we look at stage 1 for chronic kidney disease, stage 1 typically has a GFR of greater or equal to 90 mLs per minute. And so this is kind of a mild level. We have a kidney that's a little bit damaged, and it's still able to keep up that GFR rate. During this time, we want to make sure to focus on controlling those risk factors. So if our patient has hypertension, we need to make sure that it's controlled so that it doesn't further damage the kidneys. Diabetes, make sure they're controlling their blood glucose levels to, decrease the vascular damage that can occur. Stage 2, we look at, this is where we start to have that mild decrease in the GFR. So usually this is about 60 to 89 we'll start to see on that GFR, milliliters per minute. We are starting to notice that there's a slow progression of the ability for that kidney to be able to filter out waste. So we might see an increase in our lab levels. We might slowly start to see some little inklings of the kidneys not working, but overall, we wouldn't really notice it at this point unless we're checking a GFR level. Then we go to stage 3. So stage 3 has a 30 to 59 ml per hour GFR, and this is where we start to see some complications occurring. So during this time, our patients are probably pretty fluid overloaded. They probably have crackles in the lungs. They're fatigued. They're not really functioning with their erythropoietin production for those red blood cells. And so we'll see all of those complications start to occur. During this time, we really want to monitor lab levels and start to treat those complications depending on what the patient starts to have. And we're going to talk more about those clinical manifestations on the next slide as well. During stage 4, this is where we start to have a severe decreased GFR. So we're at about 15 to 29 mLs per minute. During this time, this is where we start to look at the patient's complications, but also start to prepare for some sort of dialysis to decrease the amount of fluids and start to remove the toxins out of their blood for them. We may start to talk about transplanting, kidney transplants, if it's appropriate for the patient, and that's kind of the route that the provider wants to go. During our stage 5 is a GFR of less than 15, so that number is pretty important to know, less than 15. This is a stage 5 kidney disease, and this patient requires full-time dialysis or a transplant of that kidneys because their kidneys are not working at all and they're building up toxins. They're not, able to regulate the fluid retention and hormone balance and things like that. So what you'll start to see is a full system shutdown that will affect other organs as well. Okay, so on this slide, we're going to look at clinical manifestations of our chronic kidney disease. So it depends on what level of chronic kidney disease they're on, but for the most part, we'll start seeing some mild complications at about 3 all the way to stage 5, which is severe complications. So CKD affects every single body system due to its toxic accumulation of the toxin accumulation, the abnormal hormone imbalance, and the fluid retention that occurs. So in our renal system, you're going to have that oliguria shift to anuria. So they're going to make small amounts of urine initially and then completely stop their urine output. This is due to the low GFR and the inability for the kidneys to filter that fluid out. We're going to have changes in our fluid and electrolyte imbalances. So usually they'll have a sodium and water retention, which leads to edema, that weight gain, hypertension, and those pulmonary crackles that we'll hear on lung auscultation. Our electrolytes are going to be imbalanced due to that impaired filtration, and it will lead to increased potassium levels, high phosphorus levels, and a low calcium level due to that vitamin D activation impairment. We'll see metabolic acidosis as well when we're looking at our ABGs, and so we'll just know that at this point those kidneys are pretty impaired. Cardiovascular system, we'll see hypertension. We may see some CHF or chronic heart failure, pericarditis or inflammation of that pericardium due to the fluid overload and that uremic or uremia acid irritation. Our hematological system will be impacted due to that low erythropoietin production, so they'll have anemia, fatigue, and pallor due to that lack of red blood cell production. Our GI system will be impacted due to those uremic toxins that can irritate the GI tract, so patients will have nausea, vomiting, may have uremic fetor, which is a smell of those uremic toxins on the breath, or a metallic taste in their mouth. Due to that buildup of uremia, we're also going to have potential for uremic encephalopathy. So it's going to be very similar to our hepatic encephalopathy, where they're going to have confusion. They may have those tremors or seizures and be really altered in their mental status. Our integumentary system will be impacted due to the toxin accumulation as well. So our patients may have dry, itchy skin, gray, yellow colored skin, or have what's called uremic frost. So that's a buildup of those urea crystals. And so it kind of looks like a little crystally salt on the skin. Patients will also have changes in their musculoskeletal system. So that decrease in vitamin D leads to hypocalcemia, which leads to that bone demineralization. So they can have increase in bone pain and an increase in fractures as well. So you'll see all of that occur due to the kidneys not functioning appropriately. Okay, so for our medical management and our nursing interventions for chronic kidney disease, we want to make sure to control those underlying causes. The main goal is to slow that progression from occurring, manage those complications, and prepare for any type of dialysis or kidney replacement therapy. So make sure that we do tight blood glucose control in diabetics, because remember, we don't want that blood glucose to make it worse. We want to maintain that hypertension, so keeping our blood pressure less than 130/80. We can either use those ACE inhibitors or those ARBs, according to our, if you go back to your lecture, the previous slideshow, looking at how those impact our blood pressure. We want to make sure that we treat any hyperlipidemia to help reduce the vascular damage that can occur. Dietary and fluid management is really important. So if they are fluid overloaded, not able to get those fluids off, then we're going to do a fluid restriction and make sure that we don't add any fluids onto their body. For diet components, we're going to want to focus on a renal diet, which has a restricted protein amount. This helps to decrease our urea buildup. We want to limit sodium to 2 grams per day. This helps decrease edema and helps with that blood pressure control. We want to look at our potassium restriction. So we want to do things like avoid excess potassium like bananas, oranges, or potatoes. This helps to prevent that hyperkalemia that can occur. We want to limit our phosphorus levels. This is usually found in dietary issues or dietary things like nuts, dairy, and colas. This helps to prevent hypocalcemia and bone loss. We also want to make sure to support bone health, so we would increase supplements of calcium and vitamin D as needed. For your patients that have a renal diet, just remember to teach them to look for hidden sources of sodium and potassium. So sometimes you'll see patients who are on like nutrition supplements like Boost or Glucerna shakes, but remember they need ones that are specifically for nephro patients. So one of them is called Nepro shakes. This has decreased protein levels, especially to decrease that urea buildup, and then has sodium and potassium in normal levels. So make sure to monitor for that. Make sure to monitor for medication therapy. So again, controlling that hyperkalemia with insulin, glucose, and K-oxalate, looking at dialysis needs, correcting any acidosis that could be occurring through the introduction of sodium bicarb, making sure that if they're anemic, we give them EPO or iron to help increase their hemoglobin and hematocrit. Make sure that we control phosphate levels, so we can give them calcium carbonate or sevelamer to help bind that phosphate levels and get rid of it out of the body. Making sure that we give any diuretics, especially in that early phases of chronic kidney disease, things like furosemide or Lasix to help manage that edema. During the later stages of kidney failure, we may need to utilize dialysis, and we're going to talk about that in a couple slides, the different types of dialysis, but this helps filter the blood and helps to decrease excess fluid on the body. Uh, Stages 4 to 5, this is where we would start to look at a kidney transplant and get ready for that patient to have that. So for your patients, our main nursing priorities is to monitor things like eye intake and output, daily weight, edema, lung sounds, blood pressure, and electrolytes, prevent any infection and bleeding, promote energy conservation, nutrition, and emotional education, and then teach medication compliance, recognizing complications, and helping them to follow fluid and diet restrictions as well. Okay, so now we're going to briefly touch about something called nephrotic syndrome. So nephrotic syndrome is a glomerular disorder that's characterized by a massive loss of protein in the urine, also known as proteinuria, due to that increased permeability of the glomerular membrane. So this oftentimes causes a decrease in that serum protein, so it leads to that hypoalbuminemia. It causes edema, it causes hyperlipidemia, and it causes lipiduria. So ultimately, that glomeruli leak protein, and that causes the blood to have an oncotic pressure that starts to drop. So the fluid starts to shift into the tissues, which leads to edema and has other systemic effects. So we'll go a little bit more into that pathophysiology. So under normal conditions, the glomerular membrane prevents large molecules like proteins from passing into the urine. But in this nephrotic syndrome, the damage and inflammation to the glomerular capillaries starts to allow those proteins like albumin to leak into the urine. And so what we'll see is we'll have patients that will have high protein in their urine. So usually they'll have about 3.5 or greater grams of protein per day that's lost in their urine. They'll start to have hypoalbuminemia. This leads to a decrease in that plasma oncotic pressure. They'll start to have generalized edema. So that's edema everywhere on their body as that fluid starts to shift into the interstitial tissues. And then we'll have liver compensation. So this leads to an increase in the synthesis of lipoproteins, which can lead to that hyperlipidemia and lipiduria, so lipids or fats in the urine. For your clinical manifestations, your patients will have that massive proteinuria, which you'll notice by foamy urine. So their urine is going to be really frothy and foamy. That's due to the buildup of proteins that are lost in the urine. They're going to also have that generalized edema. So they might have it all over the body, especially in that periorbital area and dependent sites like the abdomen. They may have hypotension due to that volume depletion or hypertension depending on if that compensatory mechanism of that RAS system was activated due to hypotension. Your patients will have complications that might include acute kidney injury that might progress to that chronic kidney disease. They might have hypovolemic shock if they have severe protein loss or loss of that volume in their blood. And then they might have problems with infection as well because they're losing immune proteins as well. Okay, so now we're going to look at glomerulonephritis. This is an inflammation of the glomeruli, which is our kidneys filtering unit. So glomerulonephritis is an inflammation of those glomerular capillaries, and it can lead to an impaired filtration of the blood that goes into the kidneys. It can either be acute with a sudden onset and be reversible, or it can be chronic and be slow and progressive, kind of like chronic kidney disease. The disease might be either primary, which originates in the kidneys, or due to systemic disorders like lupus or diabetes and be diagnosed as secondary. So under normal conditions, those glomerulus filter waste and fluids while helping to retain those blood cells and proteins. But in glomerulonephritis, those inflammation and damage to the capillary walls makes them leaky and allows those proteins and red blood cells to escape into the urine. So what you're going to have for your patient is changes in their urine. So you might see hematuria, which is kind of a red or pink tinged urine, all the way to tea or cola colored urine. The urinary system may also lead to edema. So your patient's going to have edema and that weight gain. They may have cardiovascular changes like hypertension or pulsing, a bounding pulse, JVD or jugular vein distension that signifies that fluid overload. They may also have fatigue or anorexia or nausea due to the accumulation of toxins in the blood as well. Let's see, for your interventions, it depends on what kind of complications you have. So it can lead to a hypertensive crisis due to the increase in blood pressure. It can lead to that acute kidney injury, which can progress to chronic kidney disease. It can lead to heart failure or pulmonary edema due to that fluid overload. It can lead to uremia or a buildup of uric acid in the blood, which can then lead to encephalopathy or seizures as well. So for your goals for your nursing interventions, you want to help to control inflammation, make sure that we monitor and manage fluid and electrolyte balances, preserve kidney function, and help to prevent complications. So some things we'll do is we're going to treat that underlying cause. So if it's due to infection, we're going to give antibiotics. So for example, if the patient has a strep infection that causes damage to the kidneys, we would give penicillin. If it's an autoimmune cause, then we would give things like immunosuppressants and corticosteroids. We'd want to make sure to manage fluid and electrolytes, so restricting fluids, restrict sodium, and restrict protein, which can help to prevent overload and reduce that BUN. We want to make sure we do strict I&Os, which can indicate fluid balance levels, and we want to make sure to administer diuretics if the patient needs help with excretion of that fluid. Administering ACE inhibitors, calcium channel blockers, or ARBs will help to prevent and treat hypertension so that it can help control that blood pressure and slow that progression. Making sure that we monitor for signs and symptoms of fluid overload as well. So monitor daily weights, blood pressure and vitals, lung sounds, and monitor the urine for characteristics of glomerulonephritis. So if you look there in the bottom left or the bottom right corner, you'll see the urine for glomerulonephritis will oftentimes be pink or red due to the breakdown of blood in the urine, and it will be foamy or frothy due to the buildup of protein in the urine as well. For patients with severe or chronic glomerulonephritis, they'll need to do dialysis, which we'll talk about later, manage anemia with EPO or iron supplements, and address any problems with vitamin D or phosphate that can lead to bone disease. Okay, with your kidney imbalances, make sure to always monitor for electrolyte imbalances. Remember, hyperkalemia can be found in kidney failure, and what you might see are changes in the cardiac rhythm. So we'll see peaked T waves and arrhythmias. So anytime you see a problem with potassium, I want you to think heart problems. So put them on a heart monitor. They may have changes in their sodium levels. This can lead to seizures, coma, confusion, and death. So make sure if you see problems with sodium, you're thinking mentation and brain. It can lead to hypocalcemia. So this is problems with our calcium levels. When we see problems with calcium levels, I want you to think about muscles. So this can lead to smooth muscle constriction, like in our throat. It can lead to muscle cramps or tetany, which is kind of a shaking or tremors in our muscles. We can have changes in our tendon reflexes as well with that hypocalcemia. So overall, cardiac monitoring, electrolyte replacement, educate the patient, and just really monitor labs. Okay, so we're going to talk about dialysis. Dialysis is required when the kidneys are not able to get rid of excess fluids and remove waste out of the body. So we essentially will need to do artificial cleaning of our blood and removing those waste. So there's two different dialysis types that we'll talk about. One is called hemodialysis. This is where the blood is filtered through an external machine, and we will talk about peritoneal dialysis, and this is where the patient's peritoneal membrane in their abdomen is used for filtration. So two different types of dialysis we'll talk about, and we'll talk about how we need to pay attention to risks and monitor those for the patient. So we'll start with hemodialysis. So hemodialysis is that dialysis that is filtered through an external machine. So your patient will have a fistula there that they might have placed in their arm, or they might have a temporary dialysis line that you'll see in their neck. This is often used to be able to take the blood out of their body. It is then put through a machine known as a dialysis machine, where an artificial kidney or filter is. It filters the blood, cleans it, removes toxins, and then it will go back into the patient through the other line into that dialysis catheter if it's temporary, or into the fistula once that's matured. Now, a fistula is the joining of an artery and a vein, so that's why you'll see it's called an AV fistula. And what's really important for you to understand as a nurse with a patient with an AV fistula is that it takes time to mature. So once this surgical procedure is done, they have a AV fistula, it's not quite mature. So they won't be able to use that right away. They will have to use a temporary line, which looks like an IV catheter or a line in the neck. They'll have to use that until the blood flow and that vein and artery are grafted together and that matures. With our patients with AV fistulas, one big thing that is always tested on an NCLEX is your ability to assess that AV fistula. So in order to assess that fistula for blood flow, making sure that it's functioning correctly, we need to make sure that we check for a bruit and a thrill. So we are actually going to palpate, place our fingers lightly over the site of that AV fistula, and what we're palpating for is we're feeling for the thrill, and we're going to feel like a vibration, and that's the blood flow from the artery and the vein. So you'll actually feel it kind of vibrating or whooshing underneath your fingers. Then you also want to auscultate with your stethoscope. You're going to place that bell of that stethoscope over the AV fistula site, and you want to hear a whooshing. So that's auscultating for the bruit, BRUIT. And so those two things will tell you that the blood flow is good to that graft and it's getting enough blood flow to survive. You also want to check capillary refill, skin temperature, turgor, and pulses on the most distal site of that graft, just to make sure that any surgical procedures for that formation of that graft has not caused any damage to the rest of the extremity. So oftentimes you'll do a radial pulse and cap refills, and just making sure that the blood flow is going to that arm. For your AV fistula, you also want to make sure not to do any blood pressures or blood draws on that site. This can damage that AV fistula, and that could really set your patient back quite a bit of time, especially if that's a mature AV fistula. So that's why we ask the patient, do you have any arm restrictions or any reason why I wouldn't be able to do any blood sugars, IV draws, IV lines, or anything in a certain arm, because they may have an AV fistula. Now we'll move over to peritoneal dialysis. So peritoneal dialysis utilizes that peritoneal membrane in their stomach to be able to use for filtration. So if you look at the picture there, the dialysate fluid, this is a fluid that helps to clean the toxins out of the patient's blood, is administered into their peritoneal cavity, so that abdomen. They're going to administer that fluid, and then they're going to let that sit inside of their peritoneal cavity for a couple of hours. That dialysate fluid goes in and helps clean their blood. It filters through the peritoneum across that membrane through diffusion and helps to clean out the blood and toxins. Then that fluid is then drained out of the peritoneal cavity. And what we hope to see is we hope to see clear fluid that is more fluid than what was put in, okay? Because we're wanting extra fluid to be taken off of the body. So that dialysate fluid helps to kind of pull the fluid out of the body as well. So main things with peritoneal dialysis is that it allows the patient to be a little bit more mobile. They can instill the dialysate fluid and then go shopping or go do whatever they need to do for a couple hours and then come home and empty that fluid out. Whereas hemodialysis, they've got to lay in bed for those 3 to 4 hours and get that dialysis filtering through with that artificial machine. So hemodialysis, or I'm sorry, peritoneal dialysis is a little bit more forgiving, allows the patient to have a normal life, and they can do it at home. But one of the big things with peritoneal dialysis is risk for infection because we have a line going directly into that peritoneal cavity. So the way we note if the patient has any signs of infection would be dialysate fluid that comes out and is cloudy. So if you see dialysate fluid coming out during peritoneal dialysis that is cloudy, you want to notify the doctor right away. This is a sign of infection. It is expected that the patient might have some abdominal cramping or discomfort when we're putting the fluid in because, a lot of excess fluid being put into our stomach kind of causes some pain. To help that, they can slow down the flow of that dialysate fluid and keep it a little bit warmer. So that dialysate fluid should be warm. If it's too cold or they go too fast, they can have some cramping. So that's an expected finding, and we can fix that. Once the patient takes the dialysate fluid out, they should have an increase. So let's say we instill 1,000 mLs of dialysate fluid in, 3 hours later, they have 1,400 out. That's expected. We want that extra fluid to come off of the body just like they would in the hemodialysis as well. So those are some things with our different dialysis types to be aware of. You always want to check that access site, make sure to monitor for infection, monitor vital signs, make sure they're safe, and ultimately just kind of keep an eye on those risk factors for each type of dialysis. Okay, so again, here is your vascular access care for hemodialysis. So this is a picture of an AV fistula or a graft. This is where you can see the artery and vein come together. Those two little green things are the needles for the dialysis machine. So they'll place those needles directly into the vein of that AV fistula. So again, watch for bleeding and infection since we're directly accessing an artery and a vein. Assess for that bruit and thrill. Make sure that we don't do any blood draws or IV starts or blood pressures on that access arm. So assess that access arm frequently for that vascular care for the dialysis catheter. So I did also want to show you in this slide continuous renal replacement therapy or CRRT. Since you do see that a lot in Mayo, especially in your complex or critical care rotations, this is a special type of dialysis for patients that are high risk, that are very fragile with their hemodialysis or their fluid and electrolyte balances, and they have kidney failure. So CRRT is continuous, meaning it's a dialysis that runs for 24 hours a day. So it's continuous, it's a low and slow dialysis so that it decreases that risk for blood pressure and fluid shifts. So oftentimes they don't have a lot of fluid that comes off like in our hemodialysis. Sometimes we can have patients who have 3 liters taken off of fluid, 3 to 4 liters taken off, and that causes quite a big shift in their fluid and electrolytes or their blood pressure. With CRRT, it's low and slow. So they're having small amounts taken off, and it's kind of a continuous 24 hours a day. Oftentimes, these patients will be given anticoagulants to help prevent clotting in that machine. So just know that there is a risk for bleeding, and so this may be contraindicated in patients that have had problems with bleeding or recent surgeries or things like that. Okay, then we have our renal transplant. So this is indicated for those patients that have severe end-stage renal disease or their kidneys are not functioning at all. We also can have patients who have had kidney cancers or things like that where they've had a kidney removal or transplant as well. For your pre-op, obviously we want to get consent. We want to educate the patient, explain to them what to expect for surgeries. During our intra-op, we're going to monitor our patient's vitals, make sure we do a timeout in surgery. All the things we talked about in intra-op for any other type of surgery is appropriate. For your post-op care, though, we're going to make sure that we take immunosuppressants. This is especially important so that the body doesn't reject the new kidney and the patient doesn't get graft versus host disease. We want to look for ways to prevent infection, so hand washing, putting them on neutropenic precautions, making sure that they're safe and we keep them clean. We want to monitor for that graft rejection, so monitor for that body refusing or rejecting that donor kidney, making sure to look for decrease in urine output, tenderness over that graft site, or signs of infection like fever or increased white blood cell count. Patients will need lifelong follow-up. They will need lifelong medications, and so, lifelong diet changes. So these patients will have lifelong changes that they have for a kidney transplant. Okay, and just a recap for your nursing priorities with patients with kidney disorders, we want to make sure that we assess intake and output, making sure that we monitor fluid and electrolyte balances, making sure that we prevent infection, that we look and recognize nutritional needs in our patients, that we're recognizing some of the common cues for things like acute kidney injury, chronic kidney disease, manage patients that might need dialysis, making sure that we monitor infection and we monitor for fluid imbalances, electrolyte imbalances, educating on medication adherence and self-monitoring, and then understanding their psychosocial support that they may need as well. I have added some NCLEX questions here to the end of the chapter for your review.